Michael McGuire. Dr. McGuire is in private practice in periodontics and implant dentistry in Houston, Texas. He is a clinical professor at the University of Texas Health Science Center, San Antonio, and the University of Texas Dental Branch in Houston. Dr. McGuire is a past president of the American Academy of Periodontology. He is a diplomat of the American Board of Periodontology. He is a past recipient of the Academy Awarding Clinical Research Award. He currently serves in the ADA Council on Scientific Affairs, and he has published over 50 publications of original articles or book chapters and lectured extensively nationally and internationally. I'd like to welcome Dr. McGuire. Thanks.
Thank you, Dr. Nevins. I think all of us are really opening our eyes to what tissue engineering could hold in the future. We've seen some great presentations this morning by Dr. Cochran and Ginobili, giving us a glimpse of what may be possible in the future. And for all of you wet-fingered periodontists like I am out there in the audience, we already know the powers of our regenerative procedures, but we also painfully know the limitations. And in my mind, tissue engineering, more than anything else out there on the horizon, holds the potential to overcome those limitations. Tissue engineering brings together the power of modern physical and chemical sciences, and as you've seen this morning, represents a spectrum of novel approaches to achieve regeneration. Tissue engineering can be defined as building on the interface between material science and biocompatibility, integrating cells, natural or synthetic scaffolds, and specific signals to create new tissues. And while the field of tissue engineering is relatively new, periodontists have been masters of using biocompatible materials to achieve regeneration for years. In fact, almost all of the chemical structures used today for scaffolding in tissue engineering have been used in periodontics for years. Chemical structures like collagen, bone minerals, synthetics. In addition to that, periodontists have also been pioneers in the use of biodegradable barriers. Again, almost all of the three-dimensional matrices used in tissue engineering today already have applications in periodontics. And whether we have known it or not, when you and I have placed these inert scaffolds into the defect and allowed them to allow the cells from the boundary of the defect to grow up, over, and through, or whether we've used membranes to create a barrier over the defect, we have been performing passive tissue engineering. And given the appropriate patient, the appropriate defect, and the right surgical technique, you and I have been able to regenerate tissues. The problem, however, has been when we are faced with more challenging defects. This passive approach, then, is no longer effective. So over the last decade or so, we have tried to say, okay, what can we do to reawaken the body's innate potential to regenerate? What can we do to jumpstart this, since this passive approach has not been effective? And what we have done is we have added biologically active molecules to these inert scaffolds or to the barrier or to the membranes in an effort to create an active form of tissue engineering. The idea behind this, as you've heard this morning, is that if we can take the appropriate bioactive molecule or factor, deliver it to the site for the appropriate amount of time, for the appropriate length, and keep it there for the time we need, what it does is it causes the cells from the periphery of the defect to migrate, to differentiate, and then they will participate in regeneration. The impetus behind this was the discovery of growth factors like BMP, and I'll share with you today the results of a study that our office was one of the centers in, that you've seen a little snapshot of in both Dr. Cochran's report and also in Dr. Gianobili's report using recombinant PDGF. The other area of research in active tissue engineering centers around living cells, where we implant living cells into the defect, either on membranes or inject these cells, and then they themselves participate and guide other cells into the activities we want. And again, I'll share with you a study that we began about 4 or 5 months ago using living cells to stimulate regeneration. I think it's appropriate for me to disclose that I am a scientific advisor and have done research for both of the companies whose products are mentioned in this lecture, but I have complete control of reporting of all the data. Now, let's begin with using bioactive molecules. I had the privilege of being in our office, of being one of the centers in a pivotal trial that to look at recombinant PDGF in regenerating intrabony defects. And before I present the results on that, I think that it's important also to share with you some fantastic human histologic evidence of regeneration using recombinant PDGF. This is a study that our moderator, Dr. Mark Nevins, his father Myron Nevins, and Dr. Camello and Schenk published in Journal of Periodontology in 2003. And I think it gives good background on what we're going to see clinically in just a moment. This is one of their cases. You can see 11 millimeter probing depth, and after flapping, you can see the sheet calculus going over the root surfaces. Certainly not the type of defect that you're going to easily go in and regenerate. They made notches at the end of the calculus for histologic and radiographic so they could come back and know the areas of the root surface that had been covered pathologically by the calculus. Here you can see the notches, and these teeth were extracted 9 months after treatment, and you can see radiographic evidence here of bone growth beyond the notch. And if we look at that tooth in a step serial section at 9 months and we focus on these different boxes, beginning with the mouth of the defect up here, we see end of long junctional epithelium, no evidence of any epithelium as we go down the root surface. See the connective tissue attaching to the root surface, Sharpie's fibers, functional PDL, new bone, and you see histologic evidence of new bone above the notch for around 2 to 3 millimeters. As we move to the mid portion, again, a highly organized PDL, Sharpie's fibers entering into the root surface, entering into the new bone, new cementum, no evidence of any ankylosis or inflammation. And as we go into the area where that was notched into the calculus, again, we see highly organized vascular PDL, new bone, new cementum, and no evidence of inflammation or ankylosis. Based on that fantastic histologic evidence of regeneration with recombinant PDGF and also some other preclinical data, decision was made to undertake a pivotal trial. It is the largest prospective randomized controlled human trial ever performed on a regenerative product in periodontics. It is double-blind, prospective, randomized, 180 patients. Each one of the patients contributed one lesion into one of each of these three groups. Beta TCP plus 0.3 milligram per ml recombinant PDGF, the other TCP plus 1 milligram per ml, and the third, the buffer alone, which was an active control, and we'll come back to that in a second. All of these patients were followed in the study for 6 months. Both clinical and radiographic endpoints were made. And I'm going to present to you the 6-month data. That's all the real data we have. But the patients that I'm going to share with you, of course, continue to be in my office, and we are continuing to follow them in our office. So I'll share with you longer-term photographs of surgical reentries as well as radiographs to give you an idea of how these patients are maintaining over time. Let's talk a moment about the three treatment groups and about the control. I've been involved in many, many clinical studies. All clinical studies are always blinded, but lots of these you can really, they're not really blinded. You say they are, but somehow you know what's what. In this study, there was no way for any of us to know what was what, because we had this TCP and we have this clear liquid vehicle. We didn't know whether it was the buffer or one of these two concentrations. And we're using an active control. Beta-tricalcium phosphate is used in orthopedics extensively, and it's a very, very fine regenerative material. Let me share with you a couple of cases of ours in our center that received the active control. Here we have a 10 millimeter probing depth. When we debride the defect, we have a circumferential defect about 4 millimeters deep. Place the TCP in the vehicle, suture. Here is a 24-month radiograph. You can see very nice consolidation. You see radiographic evidence of bone fill at 2 years. If you look at baseline in 11 months, we have 6 millimeter probing depth reduction at 11 months. And at reentry at 11 months, 5 millimeters bone fill, and this was the control. Another control, We have 5 millimeter probing depth reduction at 24 months. Look at the change radiographically. Our defect radiographically was here initially. Excellent evidence radiographically of bone fill at 24 months, just with the TCP and the sodium acetate buffer alone. The last one I'll show you here at 12 months, 6 millimeter probing depth reduction. Look at the excellent health of the tissue, no visual signs of inflammation. 12 months, change in radiograph. Re-entry at 12 months. Here's the original defect at the day of surgery. 12-month re-entry, 6 millimeter bone fill, TCP with the sodium acetate buffer alone. I point out and show you these three cases just to demonstrate and drive home the fact that we're using an active control here. If we can get this type of results with our control, then if we are finding superior results with the test material, it's going to have to be clinically significant. As was mentioned earlier, there were 11 centers, a nice mix between university settings and private practice. All of these people represent the primary investigators, and I'd like to acknowledge the work of my partner, Dr. Todd Shire, and our research coordinator on this study, Carol Waring, because they certainly contributed a lot to the work in our office. The inclusion and exclusion criteria are very broad, and I think that's important. All of these defects were at least 7 millimeters probing depth, at least 4 millimeters bone defect. 1 to 3 walls and circumferential were included. Class 1 and 2 furcations were included, and smokers up to 1 pack a day were included. In other words, this is a real-life population, not a group that we're setting up to make certain that we have easy success. They were very careful to make certain that there were no significant difference between the treatment groups when you look at clinical attachment level, probing depth, gingival recession, bone defect depth, whether it's the 0.3 group, the 1 group, or the TCP alone, no difference. If you look at the defect classification, 1 and 2 wall and 3 wall circumferential, of course that could influence result, and again, no difference among treatment groups at all. If we look at how the study was conducted, less than 2 months prior to surgery, we did informed consent. The centers were allowed to do whatever initial preparation they felt was necessary. Less than 2 weeks from surgery, we were all calibrated, radiographs, clinical measurements made, then surgery, and we followed these patients for 3 months, 6 months, taking clinical and radiographic data. Let's look at the surgery just to give you a feel for the type of defects we were treating and how the surgery went. This is one of our patients with a 7 millimeter probing depth, 4 millimeter intrabony defect. After debriding the defect, we placed tetracycline on the root surface, lavaged the tetracycline, and then placed the vehicle. Of course, we didn't know whether it was a sodium acetate buffer or the recombinant PDGF on the root surface. It was then mixed with the TCP, placed into the defect. You can see how it handles very easily, and I'll show you a video in just a moment of it. Place it in the defect, place some more of the vehicle on top, close the flap, and I think it's also important to mention that while we're beginning to utilize these fabulous new materials that hopefully will allow us to achieve things we couldn't in the past, nothing is a substitute for good surgical technique. You still have to pay attention to proper root debridement, defect debridement, proper soft tissue management, flap closure, primary closure, tension-free sutures, all of those things that we know to be important in any sort of regenerative procedure. Here we can follow the case over 2 years. This is not the type of defect that shows up well radiographically, but this is the defect at 3 months, 6 months. You begin to see more consolidation at 12 months and here at 24 months. And when we re-enter at 1 year, we see we have a 3 millimeter probing depth reduction and a 4 millimeter bone gain at 1 year. And this happened to be one of our patients that really didn't perform great home care. A very typical patient that all of us have in our practice, and even with less than great compliance, a very nice result. I'll show you a short video of this defect, and then we'll talk a little bit about how we managed the results that we achieved. Here we're probing the defect, just making certain that indeed we have the 7 millimeters that we need to enter him into the study. After laying the flap, I'm going in and using high-speed finishing burrs to make certain that the root surface is biocompatible. We're removing any accretions. I like to use this just to make sure I'm getting down to the base of the defect here. And this is a fairly shallow, it's a 4 millimeter interbony defect. Now I'm coming in with a curette, doing further root planing on the root surface. And now using the curette also to make certain that we've debrided the bony walls, getting any sort of connective tissue, soft tissue tags out of these little bony irregularities in the defect, just making certain that the defect is completely debrided. And now coming in with modified ultrasonic tips, again, getting into all the line angles of the defect, just making certain it's completely debrided. Now we take the vehicle. Of course, this time we didn't know whether it was a sodium acetate buffer or the recombinant PDGF, but we place it onto the root surface, and obviously it flows into the defect itself. That is followed then with the TCP with the vehicle on it. Lightly pack it in. You saw how easy it stayed there on my instrument as I moved it in there. We lightly pack it into the defect. We don't want to compress it too much because we want to leave space for the blood vessels and the cells. And then we just clean things up. We're going to close the flap. And then placing some of the vehicle on the soft tissue after flap closure. So let's talk a little bit about what's happening between this point and where we're at now after the video. As you saw a while ago with the controls, there's a lot going on in this defect. This is not a passive material that we're placing in there. And let's focus on what's happening at the interface between the root surface and the material that we just placed in the defect on the video when we think of mechanism of action. With the beta-tricalcium phosphate, it physically fills the bone defect, as you saw, provides a biocompatible osteoconductive scaffold for bone formation, prevents soft tissue collapse, and facilitates a stabilization of the blood clot. And as you saw in my clinical examples, it's a powerful active control. It by itself does a pretty good job. But that's not the only thing that we have going on here. We also have the recombinant PDGF, which is mitogenic. It stimulates PDL in bone cells, and it attracts PDL and bone cells into the site. And it also has some interesting angiogenic components. It stimulates and facilitates the ingress of blood vessels into this area. So we have a lot going on the cellular level at the bone to graft interface. The PDGF is stimulating, recruiting the cells in the area, bringing in cementoblasts, bringing in osteoblasts, fibroblasts, endothelial cells into the defect, and then initiating the process of regrowing the attachment apparatus. We're getting formation of new bone, new cementum, organizing PDL fibers, and if we look at my reentry here at 11 months, we're now getting a consolidation of a new attachment apparatus. When we look at the progression of what we started with to what we had at the end of surgery to my reentry at 7 months, a couple of things strike me. One is that if I look at a defect like this, I would think as a clinician that regardless of what material I place in there, I can probably fill that intrabony component. That's a type of lesion that you and I know that we can treat fairly predictably. What I wouldn't think I could probably do is fill this component of it, the suprabony component of this lesion. Yet, if you look at where we placed our graft and where we ended up, we were able to fill this beyond that point in the lesion. We grew that portion up. And so as a clinician, that really struck me, that I was surprised that we could fill that portion. I was also surprised, and was consistently surprised, at the hard cortical nature of the bone that we were regenerating here, with this reentry happening to be at 7 months. Another one of our patients, kind of a shallow 2-3 wall defect, debridement, placement of the graft, and at a year we've got 5mm probing depth reduction and a 3mm cal gain, which is very typical to what the study showed. You've seen this slide a couple of times this morning. I won't dwell on it. Basically what we found was that at 3 months, the 0.3 milligram group was statistically significant over the TCP, and that gain was maintained over the 6-month period. A more interesting way to look at it is looking at cal gain, which is called cal under the curve, which is a common way to look at wound healing studies. It allows us to compare different groups over time, and I think the take-home message here is that the PDGF appears to cause more rapid cal gain, and then that cal gain is maintained over time. Again, if we look at one of our cases, you see the defect initially, you see some calculus on the root surface. Here is at 24 months, very nice consolidation of the bone at 24 months. We have a 6mm probing depth reduction during that same time interval. Another one of our patients, 6mm probing depth reduction at 2 years. Again, you see the defect radiographically initially and what we have at 2 years. Very nice radiographic evidence of bone fill in that area. Another patient with a very deep defect radiographically and the appearance at 2 years. This was very common to what we saw in all of our patients, where we have our initial defect. At 3 months after treatment, radiographically, you're not seeing much change. At 6 months, we're beginning to see some consolidation of the defect. At 12 months, we're starting to see a little lamina dura, even more so at 18 months. And here at 24 months, we're actually seeing a little peak of the bone coming up toward the CEJ. Now, these are my patients, following them out over time. In the study, we only followed them to 6 months, and the radiographic evidence was generated from the baseline and the 6-month radiographs. They were sent and examined in a blind way, and were looked at linear bone growth, which is a change in the distance from the CEJ to the base of the defect from baseline to 6 months, and also looked at percent bone fill. This is linear bone growth divided by the defect depth at baseline. This is not a volumetric change, it's a two-dimensional change. And what we found was that radiographic linear bone growth was highly significant at the 0.3 level, above the TCP alone, and outperformed the 1 milligram per ml as well. If we looked at the radiographic percent fill, this is the amount of the defect that was filled at 6 months. Again, the 0.3 milligram outperformed the other two, and on average 56% bone fill at 6 months. One of the slides that I thought was very revealing is that the study stratified the defect classifications. All of us know it's much more difficult to regenerate 1 and 2 wall defects than it is 3 wall defects. And that's what played out, that if you look at the 3 wall and circumferential, all 3 of these bars are higher than any of these bars. But even in the easier to fill 3 wall defect, look how the 0.3 milligram per ml outperformed the other 2. And even in the more difficult to fill 1 and 2 wall defects, the 0.3 milligram per ml was highly significant over the other two defects, and even in these difficult defects, we got 53% bone fill. If we look at the proportion of cumulative bone fill, this is an interesting slide as well. You've seen it once this morning, but I think it's worth talking about again. This is the buffer alone, and this is the 1 milligram per ml, and this is the 0.3. You see how each one of these are clearly separate from the other. And at any point on this curve, no matter where you look, the 0.3 milligram per ml outperforms the other two. This type of graph helps speak not just to statistical significance, but also to clinical significance, because 50% of the patients that received the 0.3 achieved at least 50% bone fill, where 50% of the patients that received the buffer achieved about 20% bone fill. And that speaks to what percent of the population actually have experienced a significant benefit. And clearly, the 0.3 milligram per ml group experienced a significant benefit. And if we go back and we look at the same patient that I showed you the radiographs, and we do a reentry, we see at 12 months we have 4 millimeter bone fill. Again, look at the hard cortical nature, the way the bone looks here at 12 months, a very, very nice result, and one where we're generating bone above the osseous crest, not just filling in the defect itself. So to summarize the pivotal trial, again, this is the largest prospective randomized human clinical controlled trial ever performed on a regenerative product in periodontics. If we look at the recombinant PDGF plus the TCP, there was statistical improvement at cal gain at 3 months and cal area under the curve between 0 and 6, interpreted as more rapid cal gain, and then that cal gain is maintained over time. Also, significantly more linear bone growth and percent bone fill at 6 months, just another one of my cases showing radiographically these changes. And while those are the results of the 6-month trial, my personal feelings are, and how I have experienced this in our office, is number one, it's a very easy material to use. It's not hard to deal with. I was impressed with soft tissue changes. The tissue heals very rapidly with this. Our probing depths, our clinical attachment levels are maintaining well over time, and we're now to 24 months on all of our patients. And especially the radiographic changes were very interesting. You know, it doesn't take some complex mathematical formula to determine if there's something positive going on here. The radiographic changes are very dramatic. I'd also like to share with you a pilot study that we've just completed using a synthetic growth factor and a scaffold versus plus a collagen membrane versus connective tissue to cover root surfaces. You know, all of us would love to find some sort of material that we don't have to go to the palate in order to cover root surfaces. Just to give you a feel for what we're doing, this is a control on one of our patients, a fairly broad, deep recession defect, taking our preoperative measurements. This happens to be the control side. I've root planed and scaled. I'm placing connective tissue graft over these two roots. In the study, we won't allow two teeth to be together, but on the pilot portion we did. And I've currently advanced the tissue over my connective tissue graft. And here's what we see at 3 months, getting very nice root coverage over our lateral incisor and our canine. Here's the same patient opposite side, our test tooth, intraoperative measurements, root plane and scale, intraoperative measurements after flap elevation, and now we're delivering the growth factor, placing the scaffolding, which will provide space for regeneration, just comparing the thickness of the collagen membrane to the connective tissue that we're using. We trim the collagen membrane, place it over our scaffolding and the synthetic growth factor, elevate the tissue over that. Here's what we have at 3 months with our growth factor, and you can see very nice root coverage compared to what we had before. Also note the apparent increase in the amount of keratinized tissue over the root surface compared to what we had at baseline. If we follow the test control to 6 months, this is our connective tissue graft, and this is our test graft using the growth factor and the matrix. And I'll leave it up to you as to what you think about those two. I just share one more patient. This is just the 3-month with, this is the connected tissue, very typical look, connected tissue at 3 months. This is what our test looks at 3 months, same patient, opposite side. And if we compare the two at 6 months, again, this is the connected tissue, very nice root coverage, and this is our test graft. And if we look at both of those, the things that strike me with both of these patients is the amount and predictability of root coverage that we're getting with our test graft compared to the control, our test graft compared to the control. Look at the soft tissue contours on the test graft as opposed to the flatter type contours that you typically get with the connected tissue, and also note the increased amount of keratinization or keratinized tissue that we have with our test grafts. One of the things that makes the connected tissue graft appealing to a lot of clinicians is the fact that we do have a nice zone of keratinized tissue. Lots of the other grafts that we see where we're trying to find other ways that we can graft over these root surfaces just don't yield the keratinized tissue that we as clinicians like to see, and certainly we're seeing that in this. So we hope to take this pilot study now and move into a study that will start shortly after the first of the year with 30 patients, and hopefully next year we can provide results on that. Let's move from using bioactive molecules to using living cells. And before I talk about our study, I need to recognize the work of Dr. Bausma and the University of Texas Health Science Center in Houston, the dental branch in Houston, for their work showing safety using autologous cultured fibroblasts. We took this safety information then and moved it into our trial. We are currently, we are about 5 months into this trial, and so I'm going to share with you my impressions and give you an idea of what we're doing, but I don't have data, but I think it's worthwhile to share nevertheless. One of the last frontiers in periodontics is being able to regenerate that papilla. Nobody can show you on a predictable basis that they can do that. Lots of people will show you, here's a clinical case, but nobody can show you time after time. And so what we're trying to do is to use a novel approach. It's a patented technology in which we're injecting the patient's own cultured and expanded fibroblasts into that papilla. We take a small biopsy. The biopsy is then sent to the laboratory. From that biopsy, the fibroblasts are extracted. They're reproduced and grown and then placed in an injectable medium. We take then the patient's living fibroblasts, we inject them into the papilla. The fibroblasts then produce collagen and expand the tissue. So what we're talking about here is not injecting a filler. We're not injecting collagen, we're injecting living fibroblasts that then produce collagen to expand the tissue. We're just beginning to understand the complex intracellular interactions between gingival fibroblasts and their relationship to the structure of the periodontium. They're much more than these mundane little things that I learned about in dental school and later in my periodontal training. Gingival fibroblasts have a great deal of phenotypic heterogeneity and theoretically can contribute to regeneration through their supplying undifferentiated mesenchymal cells. You can get more UMC cells from gingival fibroblasts than you can from dermal fibroblasts, and given the right stimuli, those UMC cells can transfer into bone, cartilage, a number of tissues. So in our study, we have 20 patients, 118 total test and control sites, but we have 40 matched randomized test and control sites, meaning we have 2 primary test and control sites. We've tried to match the defects, and then we have a lot of other sites to allow us to collect more data. Our primary endpoint is change in baseline from the papillary height to the base of the contact area, and we're measuring that with a probe. We're also making models both at day 0, at 4 months and 12 months, and coming in and measuring them with a digital caliper. We're also interested in hard tissue changes as well as soft tissue changes, because theoretically these fibroblasts could influence hard tissue changes as well. So as secondary endpoints, we are looking at change from baseline from the distance from the tip of the papilla to the alveolar crest. Here I'm punching through that papilla, sounding to bone, so we're measuring the distance from the alveolar bone to the tip of the papilla. We're also measuring the distance from the alveolar bone to the base of the contact point. We're also following these patients radiographically as well. So we take a small 3 mm punch biopsy, usually from distal to the second molar. The biopsy is placed in a little vial, sent to the laboratory. It takes 2 to 3 weeks to create a cell line and approximately 4 to 6 weeks of incubation to generate 20 million cells per ml. Before these are delivered back to us, they are banked and they can be kept virtually indefinitely in liquid nitrogen, allowing kind of a fountain of youth effect. It's kind of neat, you know, that I could take my daughter's 17-year-old fibroblasts and we can then bank them, and then when she's 40 and she wants to do something about that crow feed, she can use then her 17-year-old fibroblasts. They're then sent back to us in a little thermos, and if they, again, what we have here is not collagen. This is 99.5% pure fibroblasts, and if they're injected within the first 12 hours, they're 95% viable. Within the first 48 hours, 85% viable. But, you know, I don't think there's a dentist in the audience that wonders, okay, how are you going to inject that into the papilla and make much of a difference? Because all of us have injected local anesthetic in papilla, and you know that you can't get much volume into that bound down tissue. Well, of course, we face that problem as well, and in an effort to overcome that, we created what we're terming the papilla priming procedure. Again, those of you who do surgery, you know when you see that patient at 7 days, especially if you've done a graft, the graft is swollen, maybe the interproximal spaces are feeling great, and you feel like you're a hero. Well, you also know that that swelling goes down. How can we then use that transient phenomena and turn it to our advantage? So we're going in at the alveolar crest with an Orban knife, basically pivoting that off of the alveolar crest, creating a little space. We then go in with a curette and follow the alveolar crest to the lingual, again, just creating a space here, then taking a 12B blade and going down the papilla, not excising through it, but going down toward the tip so that we have somewhat of a little T lesion. What that allows us to do then is to create a little space here and allow our injection to get into all the components of papilla, the bone, the periosteum, and the soft tissue components. So if you follow this papilla priming procedure over time, here it's at day 0, here we've completed the procedure I just showed you, and you note now at 7 days you have some tissue swelling. But if you don't do anything, at 21 days it's all back to normal. Again, I think if we think about what's going on here on a wound healing level, it might make it more sense. If we think about what the phases of wound healing, that typically most people think that wound healing has 3 distinct phases: the inflammation phase, granulation tissue formation phase, and matrix formation and remodeling. And when you look at a temporal example of this, it looks highly structured. But in reality, in nature, these different phases can overlap a great deal, and the time necessary for each of these phases can change a great deal. So can we manipulate this then to our advantage? Well, if we do our papilla priming procedure, within seconds of our papilla priming procedure, plasma proteins, primarily fibrinogen, coats the wound surface, and the process of wound repair begins. Within an hour of that papilla priming procedure, we begin the early component of the inflammatory phase. Neutrophils begin to come into this area, beginning to engorge the lesion, and within 12 hours, we see swelling of the lesion beyond baseline. So we now have swelling in our papilla. Also at about 12 hours, we're seeing the production of the natural fibroblasts to begin to increase. At 3 days, we move from the early to the late component of the inflammation phase. You see that we continue to maintain swelling over baseline, but it's looking a little bit different. We're finding that the neutrophils are being replaced by macrophages. The macrophages are producing growth factors that are supporting matrix deposition, fibroblast production, angiogenesis, and we continue to be swollen. At around 5 days, we begin to enter into the granulation tissue formation phase. The natural production or increase in the production of native fibroblasts begins to peak at around 5 to 7 days. And along with that peaking of fibroblasts, the collagen accumulation that comes along with it begins to plateau. Then we begin to see wound contraction, and at 21 days, the wound is healed, and in our case, because this was a controlled surgical insult, we're back to where we were before. Well, how can we take this and turn it to our advantage? As a rule of thumb, most people feel that the amount of tissue you either gain or lose in a wound depends on the length of the granulation tissue formation phase. For example, in a wound where tissue is lost, generally you have a very short granulation tissue phase. And the bottom line is that the production of native fibroblasts and the collagen accumulation can't keep up with the amount of tissue lost in the wound, and you have a net loss of tissue. If we could do something to expand that granulation tissue phase, then theoretically we could end up with a greater amount of tissue at the end than we had at the beginning. And that's what we're going to try to do by infusing the patient's own fibroblasts at certain points during this healing process. So we do our biopsy, we do our papilla priming procedure, and we time our first injection at 5 to 7 days. We time it at 5 to 7 days because that's the point at which the body is beginning to, the native production of fibroblasts is beginning to wane. So we want to infuse it with either an injection of 20 million cells per ml of fibroblasts or with our placebo. Here's what it looks like. This happens to be the second injection on this patient, and it looks very much like what you would see when you inject local anesthetic. Keep an eye on the papilla. You see it begin to blanch as I'm injecting the cells into the papilla here. I find that I can inject somewhere between 0.3 to 0.4 mLs into the papilla. That translates to about 6 to 8 million cells, million fibroblasts that we're injecting into the papilla. Now, we're not just injecting it once, we are dosing this. Dosing schedules are common in medicine and in tissue engineering, not something we typically do in dentistry. But again, we're timing these at around 7 to 10 days. We're coming back and we're hitting these papilla again with another series of injections, trying to extend this granulation tissue phase out and trying to gain tissue. Now, if we look at the medical literature using this material, this is a slide on dermal depressions where they've taking dermal depressions, they're injecting the same material into the dermal depressions, and here's a biopsy at 6 months. You see here more fibroblasts, more collagen, no signs of inflammation. They've taken these same cells in animal studies, labeled them, and found that the cells are still present and active at 5 months, producing fibrinogen, elastin, glycosaminoglycans, collagen, increasing the dermal thickness. And where they've taken punch biopsies in humans, they find the dermis is thicker. Mechanism of action is that these fibroblasts, they are incorporated into the natural architecture of the dermis and then begin to either stimulate native fibroblasts to produce more collagen or undergo nascent production of collagen themselves. So our experimental concept is that we're going to come in and we're going to infuse the patient's own fibroblasts at critical points, hoping to increase the granulation tissue formation phase and result in more soft tissue growth in the papilla region. We're following these patients at an acute endpoint of 4 months and then following them to 12 months. We're looking into that for 2 reasons. We want to see what we get at 4 months, do we maintain it to 12 months? But also, theoretically, we may see an increase from the 4-month to the 12-month, even though we've not done any other injections. Again, if you look at the dermatologic studies and some of the plastic studies that they follow for 6 months, they find that they are getting an improvement at the 6 months from what they had at the 3 months, even though no further injections took place. Again, the idea is these fibroblasts are injected in, they undergo 1 or 2 mitotic replications, whatever the host needs, and then they set and produce de novo production of collagen, either sustaining or perhaps even improving the result over time. I'll just share with you a few cases that we have. This is a 4-month post-third injection. This is how the patient presented initially. You can see the papillary insufficiency, and you can see where we're at here. Another patient 3 months after the third injection. Again, you can see the blunting of the papilla here initially, and you can see what we're getting as it's filling in here 3 months after the third injection. Again, another patient baseline at third injection and 2 months following the third injection, seeing a nice progression of tissue fill into the papilla region. Another patient looking at baseline, almost complete blunting of the papilla here, You see it starting to fill in at the third injection. This is 2 months post-third injection. And note not just how the tissue is coming toward the contact point, but note what appears to be the volume increase. You know, this is a three-dimensional increase, not just a two-dimensional change. Another patient, baseline, 3 months, and pretty much complete fill of the papilla, and again, a significant volumetric increase in the papilla 2 months post-third injection. And the patient that I showed you initially, here she is 2 months post-third injection, and you can see the change that we have at this point. So we have to ask ourselves, you know, what's our new grafting instruments going to be in the future? And I think as far as conclusions, the combination of the TCP plus a recombinant PDGF in intrabony defects appears to be a very positive thing. The study, 6-month study, showed that we have statistical improvement in cow gain at 3 months, more rapid cow gain, and it's maintained over time, that our bone growth is certainly affected by this in a positive way. I look forward to using this on my patients in the future outside the study. If we look at the growth factor plus scaffold versus connect tissue graft, you know, we don't know. Looks interesting. Check with me next year and I'll tell you about that one. And same thing with the autologous cultured fibroblasts. This is really looking at something completely different than we've done in the past, looking at it in a different way. I think we're going to be doing that in periodontics. We're going to be managing things in different ways than we've done in the past, and hopefully that will result for not only growth areas for our specialty, which we certainly need, but also, and more important, predictability for our patients in ways that we couldn't have imagined years ago. So it's been my pleasure to be here with you this morning. We appreciate you coming out on the last day of the meeting, and I look forward to any questions that you may have in just a moment.